Good afternoon, everyone. My name is Angelica Hasibuan. I am a provisional counselor and currently doing my placement at the Mental Health Foundation Australia, and I'll be your host for this webinar today. I begin by acknowledging the Wurundjeri Woi people as the traditional custodian of the land on which I live and work, and pay my respects to them, their culture, and their elders past and present. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank each and every one of you for attending the Melbourne Intensive Therapy Program, a short form treatment for OCD. I would now like to invite our presenter, Dr. Christopher Morgan. He is a clinical psychologist with over 30 years of experience in the provision of psychological services across a range of people from community health centers, private psychiatric hospitals, work cover, TAC, victims of crime, and in private practice. Dr. Christopher Morgan has a special interest in anxiety and phobias, depression, PTSD, OCD, shyness and social skills defects, and smoking cessation and internet counseling. Please join me in welcoming Dr. Christopher Morgan.
Okay, so I'm on. Well, thank you everyone for attending today, and this is a very special interest of mine, the short form treatment of OCD. In fact, it's been an issue throughout psychological treatments that we're always trying to reduce the amount of time that it takes to help people to function better. And in recent years, there's been a lot of interest in the short-term treatment, and it's been particularly sparked by the emergence of a Norway origin program called the Bergen 4-day treatment program. In my work with OCD, it is all from a private practice clinic. And in fact, much psychological work is done through private practitioners. And OCD is a very serious condition. And one of the big problems that we've got is a lack of experience and a lack of skills in therapists, like starting even back in days at training. But then when you come into the world of private practice, we find that OCD is not well handled. And the reasons for this is it's a very divergent and complex condition, and it has a very high level of trauma load. And it's not exaggerating to say people's lives are ruined by OCD. And family life is ruined, relationships are ruined, and the person can be condemned to many years of heavy psychological load. We can also say that treatments are advancing, and the topic of today is about a program that we ran over the last 2 or 3 years because of COVID. I think we started in 2020 and we finished our gathering of data and treatment in about 23 and 24. And the next slide will show that our work has been published. If we go to the next slide, thank you. Yeah, so it's been published in July of this year in a British journal, an outcome study of an intensive outpatient exposure and response prevention treatment or therapy for obsessive compulsive disorder. So we're very pleased about that because the idea of that particular British journal is that it's an online journal for therapists, supervisors and trainers in all matters of psychology. What we were hoping to do by publishing the study was to enable people who are interested to follow the work that we did and also have access to the treatment manual that we used throughout our study. And so if we go to the next slide, the aims of the program were to evaluate the effectiveness of an intensive ERP program for OCD. Now, I mentioned before that the psychology world, or the world of OCD, was tipped on its head about 5 years ago when very dramatic outcomes were gained by the Bergen 4-day treatment program. In fact, I had done an informal study of our work, and I was blown away by the fact that the outcomes of the Bergen program were 50% better than what we had achieved in our informal study. So we decided to examine our program in a more intense way. So long-term treatment gains at 6 months and 12 months, and to report on what our findings were in terms of response and remission outcomes, and to consider the broader implications of short-form ERP in treating OCD. You can go to the next slide. So I might just say in that sense, people will come across OCD treatment, OCD patients, but they haven't necessarily got the protocols or the experience to deal with them. So what we are, and many other sources of interest in OCD are doing, so there's a lot of online work. There are a lot of books available now, and but this specific aim of this treatment program of ours is to provide the knowledge and background in applying exposure and response prevention. When I was first involved in in my early days as a psychologist, there was a gentleman wrote a book called The Imp of the Mind, which was a metaphor for the way in which OCD completely dominates a person and will jump from issue to issue and completely confuse the person and overwhelm the person, and that would disrupt their lives at every possible level. I remember reading one of his books, and I remember very distinctly he said, if you can think of anything that would reduce your anxiety, don't do it. Now, that struck me at the time. So what he was saying was, don't associate some gimmick with your reduction of anxiety. And what that's evolved into is that the key change behaviour is response prevention. The person needs to learn to face and accept the content of their intrusive unwanted thoughts or the images that come into their life. But what we don't want people to do is endless rumination and endless rituals, which can be and are so destructive of people. And I'm talking about that range of issues from lengthy showering and checking whether the doors are locked or unlocked, and developing rituals that can take hours and hours in a day. So it's very hard to believe it that a person's life and the life of those close to them can be completely dominated by OCD patterns. So just bear that in mind, as what he was saying. Don't get caught up in gimmicks, because the images seem real and the thoughts seem real, and the imagination can create such intense reality, but it's not real. It's just imaginary. And so we have to try to teach people to not be bluffed by the intensity, the repetition, and the power of OCD. Now, the details of our study, 21 patients, they came through our normal channels. We were supported by a philanthropic grant, which enabled us to cover all out-of-pocket costs. OCD is really a very difficult condition, as I've mentioned, but it's also very expensive to treat. And we couldn't do the study unless we had every person in the study at the same basis, that there was no cost involved in their treatment. We then had 4 different stages of the program. One was to gather the pre-data, so what level of OCD they had, what severity, what other conditions they might have, what their situation was in general, and then judging whether or not they were suitable to participate in the program. And if they weren't able to participate in the intense program, they were given treatment and support in our normal programs. The actual treatment phase was a 2-day per week over 2 weeks. So we're talking about 4 days. And the key to it was we were providing one-to-one therapist-patient relationship. And each group was consisted of 3, and we had 7 cohorts to make up the 21. The next phase was a supportive phase where we kept in touch with the patients by checking in twice a week to see how they were going in terms of the filling out the protocols and doing the exposure and essentially doing the response prevention. And then the final phase was the crunching the numbers, the data pre, post, 6 months and 12 months, and the key measures of the OCD itself, which is measured by the major tool for measuring it is called the Yale-Brown Obsessive Compulsive Scale. We call it the Y box, and that is the most internationally recognised measure of the severity of OCD. And we had other measures of mood and obsessional thinking and general functioning. I mentioned already about the COVID delaying the treatment, but it also enabled us to make a change to our protocol in that some of the patients were treated with telehealth, which has become part of our daily lives now. Many people have access to treatment that would not have otherwise been possible. Next slide, thanks. So in terms of the severity of the patient group, there were the range of YBOX scores was 19 to 39. Now, 19 is in a mild to moderate level, and up to 30 in the 30s, high 30s, it's severe, extreme OCD. 5 had moderate symptoms, 15 moderate to severe, using other criteria from other researchers. All had one or more other comorbidities, including depression, panic, social anxiety, and trauma. There's one question which I'll answer more fully later, but you can see from our group here that of the 21, we had 12 indicated a trauma trigger. The onset for about half of them was early childhood onset. 7 had an onset at adolescence and 2 as adults. The group was 12 male and 9 female. And the education is an interesting thing there because, again, I guess it's because it's a private clinic in an inner suburb of Melbourne. A lot of the people that were in it had tertiary education, and so it was a unusual group in that sense. Next slide, thanks. Now this is a visual presentation of just the Y-box score, and it's got some interesting characteristics, and it just shows that in all cases there was a reduction in the Y-box score. This is each individual person's Y-box tracked over we didn't necessarily get 100% of people doing the 4 stages like pre, post, 6 and 12, but we had a pre and post for the whole 21. So there's it indicates is that just over the main changes occurred in that 5-week period, which included the 2 weeks of intensive treatment and the 3 weeks of support, and then it just levelled out because they had no further, some of them did have some contact, but mostly they were not seen by us following that treatment. This was also the case with other variables that we measured. There was an effect, a dramatic effect in the first 4 or 5 weeks, and then a levelling out. But it's quite an interesting way of looking at it. That there was no doubt that the intensive 4 days and the supported 3 weeks were crucial, and that's something that we have to work out why that might be, because there was a lot of change and there was a consolidation of learning, which I'll explain a bit later. Next one, thank you. So in terms of the key results, 1/3 were in complete remission at the end of the treatment. So that is not, we're not claiming that as a sort of a major thing, but it just showed that the program was completely successful for those 1/3. And then a further quarter showed a treatment response, but still with some residual symptoms. Again, it's a very hard condition to just shake off, but people will often have residual symptoms, which then, depending on the support they get, may or may not interfere with their lives. And then of the whole group, as it says in the second point there, that 90% of the participants had some improvement, some at least partial improvement, and 1/3 were in full remission. So our program was comparable in terms of outcome with other CBT programs. Now, when we're talking about other treatment programs, we're talking about some of them were hospitalised for 3 months or 3 weeks, or some have several years of treatment. So it's very pleasing to think that the intensive program had those good outcomes, but we're not claiming that we're matching the more outstanding findings of the Bergen 4-day treatment program. Next slide, thanks. So if we define the outcome parameters a little bit more closely, so we use the Y-box as the measure which everybody understands in the area. But the other thing was we did a clinician rating, which was a clinical global improvement measure, and there are now recognised criteria for determining the usefulness of different treatment programs. And the first one is what we achieved in that at that group of 7, which was the treatment response was a 35% reduction in the Y box and a clinical global improvement of 1 or 2. Now that measure was a measure which ran from 1 to 7, where the 7 would be no change and quite severely disabled still. The partial response was still very impressive in the sense that it was a 25%, 35% reduction of the Y box and a clinical global improvement of a little less than 3. Then the other characteristics of remission, which was, that is, the person has no longer clinical levels. Just go back, please. Go back. So we'll still go back to that. Yeah, that the Y box. I'm just having a bit of technical difficulty here, but I'll just try and say that the aim of the major programs, when we first did our internal study, well, about 20 years ago, we had Y box scores which were just below the clinical level. So say the people might have been at 28 or so, and they were at below 16, which is below a clinical level. But the contemporary outcomes are that scores of 13 or less are considered a benchmark, and our overall average reduction was, the overall score was 28, and our average reduction was down to 12 or less. So that, we're very, very close, but the Bergen programs are more like 10 and 11. They're more and more long term. Next slide, thanks. So just looking at the mechanism of change, there was a large effect of the treatment on obsessive beliefs. And it's one of the remarkable things about people with OCD is that they have, we know from wide data collection that everybody has nasty thoughts. Everybody has weird thoughts. Everybody has unsettling thoughts. And but what's characteristic of OCD is that these thoughts are seen as highly likely. They can't sort of have the thoughts pop in and pop out. The thoughts stick, and so what we have to try to help people to see that the number of people with OCD is between 1 and 2, maybe 3%, and but 97% of people on average, they all have weird thoughts, but they pop in and pop out. Whereas when these thoughts grab the person, dominate the person, they ruin their lives. Now, what we are pleased to be able to say now is that using sophisticated CBT, we are able to help people to not be bluffed by the presence of the thoughts, and to recognise that the thoughts can be just sort of non-conscious thoughts, and they pop into our minds and they confuse us. But the more we think about them and ruminate about them and worry about them and try to counter them, that's where the pathology lies. Now, the second mechanism of change was that what we're doing here, we did it in a single practice. We had three of our clinicians that have worked together for a long, long time, 10 or 15 more years. So it can be adapted to single or multiple practice clinics. And it's Australia has got that limitation of distance, and you can have people way away from treatment programs, but if they've got a manual and a proven program, they can have confidence that they can bring about a useful change for the people. Now, because time's running out, I'll just make the point here about what we think the change mechanism is that when you learn new information, what has to happen is that has to be stored in memory. And in the last 50 years, there's a discipline grown up called neuroscience. And neuroscience is contributing a huge amount to advancing treatments for mental health. And so in order for, as I said, when you get new information, you've got to store it as memory. And then you've got to consolidate and reconsolidate that memory so that it changes from being a short-term memory into a long-term memory. So we call this adaptive learning, that you can actually, over time, consolidate new circuits in your brain, which we call neuroplasticity these days. But using the one-to-one treatment, using a deep knowledge of the nuances of a particular person's condition, we can help them to formulate strategies that will enable them to manage their OCD. I mean, it's a remarkable thing that the human mind is it is the most developed organism in human history, and probably getting better and better as we go. But what we do know from human experience is that we've got this ability to internally represent our experience, whether it's past experience, future experience, or present moment experience. But when we represent that in our mind, it can be very frightening. So that a person, that intense representation in the mind can bring about thoughts, bring about feelings, can bring about sensations, and just bring about an overall stultifying effect on the person. Now, what we have, however, we have got a learning mind, which is, we call it the self-aware mind. It's the highest form of adaptive functioning. And this is a unique quality of humans, which neuroscience is working through. There are theories about it and a lot of disagreement, but there's a lot of belief that the human mind can hold out in front of it simultaneously a series of responses to a problem. Now, what the choice is then available to that person is to choose, consolidate, reconsolidate, and develop a skill that will enable them to manage their life more effectively. Now, one particular example of that in modern times is we're all familiar with mindfulness. Everybody's heard of it. Some people are sick of hearing of it, but it's an amazing skill which enables us to focus our attention. And if we are able to focus our attention, we're not bluffed or disrupted or put off course by intrusive, unwanted thoughts. It's one of the key mechanisms of change in OCD treatment because that's the basis of response prevention. that the person is willing to face the things they fear, accept that their origins are within themselves. There's not some force directing them. It's their own mind is, yes, it can be our own undoing. And what we've got to do is continually reframe our situation into a values-driven life. And it's sometimes a feature of OCD is that the person is so driven by their symptoms that they are not conscious of the effects on others. And the lives of other people are often dedicated to managing or trying to help their loved one. But regrettably and unwittingly, they're actually accommodating them and helping them to maintain that ritual-driven life. And we have to kindly and in a supportive way help people to understand that giving the person reassurance and modifying a family program so that the life of the OCD person is the dominant feature, that is a recipe for disaster. Next slide, thanks. Oh, that's the end of the slides. So that's yeah. So what we might do, if I can, is I had a couple of questions came in, but we can also take some questions from the floor. Is that okay, Angelica?
Yeah, sure. I'm as I see the Q&A box, I haven't seen any questions, but I actually already got some questions from the pre-submitted ones for the webinar. If that's okay, I can share you the first question, Chris.
Yeah.
Okay, so the first question is OCD largely an inherited or genetic disorder, or does it develop as a result of trauma?
All of the above. Yes. So there is definitely there is a genetic factor in it, and but I wouldn't go as far as to say it's a genetic disorder, but like a person will frequently report that a parent has OCD or an uncle. So there is that element of genetic factors in everything we do, but it's not genetic in the sense of say a Huntington's chorea or something like that. No matter what you do, if you've got the gene, you're going to have the disorder. No, not that's in that sense. I'm saying no, because it's a behavioural and cognitive driven condition, and it's treated by behavioural and cognitive strategies, in addition to some, because there's so many comorbidities associated with it, there are other treatments also that are being implemented for OCD. Well, of course, medication, some patients respond very well to medication, which then helps them to apply the primary treatment, which is exposure and response prevention. We must never get away from that without exposure and response prevention, OCD will not be manageable. Now, the question of trauma, as I mentioned, yes, it is frequently triggered by trauma, which, as in our particular group, there were, I think, off the top of my head, I think it was 12 indicated at childhood onset, and some of that trauma is obviously related to adverse childhood experiences, but it can also be developed during bullying and not thriving in the school setting or family violence and stuff like that, which obviously sets people up for post-traumatic stress. Now, I've lost what was the last bit of that question, Angelica?
Yes, actually, you kind of like answered the question. So basically, it's asking about whether it's inherited genetic disorder or development as a trauma result. And that's
There,
the
there,
first question. Yeah.
there is some. There is. We need to also say that obsessional. So obsessive compulsive disorder is sort of driven by obsessionality. But there are other conditions that come into like a broader spectrum disorder. So you will find that people that have impulsive or compulsive on that span, they also come into the broader categorization of the obsessional spectrum. So, but actual obsessive compulsive disorder in a classic sense is much more defined, and it's limited in number. Like 1 to 3% would have that, whereas a larger percentage would have other related conditions, including anorexia nervosa is in that broad spectrum of obsessionality, gambling, addictions, things like that, because the person has got that sort of drivenness, that their thoughts are unchangeable or apparently unchangeable. So the French call it the fixed idea. So you can't, if a person, horse to the water, if you take a horse to the water, you can't make it drink. So if you have not got a willingness to change or have not got a openness to new experiences, it's very difficult to bring about change. Now the next one.
Okay, sure. Next one, I read it from the question box, from Zain Khalid. What can be the most effective treatment plan for OCD in all years of your experience?
Well, there's no doubt about it. Is coached OCD, that is one-to-one OCD, and in intense forms, and because it's going to bring about that adaptive learning that I've referred to. So that if you think about it, that if a person is stung by an intrusive, unwanted thought, just comes out of nowhere, and the person is then ruminates about that. Just one particular one might be, would I harm my child, which can be a perinatal OCD condition, or a person might feel they'll harm a child in the kindergarten or in the shopping centre. Now that thought then dominates them. Now what we've got to try to help people to say that it's just a thought, and there are many other thoughts that come into your mind, but the fact that it's there and you continue to blame yourself, I'm horrible, I couldn't possibly tell anybody about this, and to withdraw into prayer about it, or washing your hands about it, or whatever. I mentioned earlier about how the human mind has got this capacity to internally represent their experiences. Now, when those experiences are endless thoughts, or they're contortions in the body. So a person might feel, I've got to swallow, I've got to swallow, I've got to swallow, and otherwise I'll choke. These sort of things are driven by anxiety. Now, what we've got to try to help the person to do is to step back from that, sort of create a pause and wonder, this experience I'm having is part of me. But the more I go through it and intensely analyze it and blame myself about it, it's going to take over. Whereas what we want people to say, it's only part of your experience. Don't make it all of your experience. Now, so we've got to then see that we do know that if you sit with anxiety, over time it will pass. It's one of the fundamental ways in which exposure and response prevention works. You actually sit with the person and you say, here's this issue you're worried about. You're worried about, did I harm that child that just walked close by me? You say, let's go to the shopping centre, let's sit there and not spend your time scrolling on the phone or reading a magazine. Just take in the environment around you. Now, after 2 minutes, you say, are you still as anxious as you felt when you came in here? Now, the person is either going to have the anxiety at the same level, or their anxiety is going to go up, or their anxiety is going to come down. Now, over a period of coached OCD, we can teach the person to habituate. So that intrusive and unwanted thought, in our particular case, my advice is that within a month, 6 weeks, that person can say, I don't have that thought anymore. Or if I have that thought, I just let it go through to the keeper. So if you let it go through to the keeper and shift your attention back to your stuff, what are you here for? And what else is on your mind? Make a phone call, ring a friend or whatever, arrange to meet someone. Those values-driven things they're going to enrich your environment, whereas these horrible put-downs, you never started what you said you'd do, you're horrible and nobody likes you. All this sort of inner critic stuff is what damages our capacity for change. So just let me go back and just say that slow, repeated exposure and response prevention leads to habituation. That is, the person is not doesn't have to avoid going to the shopping centre, can go there and can manage that experience. Now, another intervention is that even though you feel distressed, it doesn't mean what you're thinking about is going to happen. And the only way you can, again, demonstrate that is through coached ERP, whereby the person is supporting, understanding, and saying, don't keep ritualising. The more you ritualise, the more powerless you feel. And one of the insights is saying, don't keep putting a log on the fire. If you would do a ritual, you're consolidating the OCD belief. If you do response prevention, you're growing stronger and running your life according to your clear values, and also maintaining that willingness to challenge. That's what we've got to have. And my belief is ERP is the key to change. Look, and it's so widespread. Like, I know it's, as I said, 1% to 3%, but it's such a destructive condition that there are many, many clinics all over the world trying to work out what to do with OCD. But the primary treatment program is understood to be exposure and response prevention. Okay,
Okay. Thank you, Dr. Chris. So the third question is according to the chat box. There is also a question that asking about, is complete remission of OCD possible with the help of medicines, and how does that work?
help with the use of medicines. Is that what you said?
Yes.
Well, I won't. I'm going to sort of dodge that question by saying I'm a psychologist, and so I'm very respectful of the role of medicines in the treatment of health, and but there are some conditions which, and as I mentioned to you, I mentioned to the group, the the new information that we're getting from neuroscience is showing us that that the way to overcome OCD is not to think of it as say, what's the magic pill? Or if I take this, I'll be fine. Um, some people make an excellent response because their underlying condition might be depression. And so they respond to the depressive component of treatment, and they can not be bluffed by the all those thoughts that people have about themselves, that they are horrible, and the more they think about this, I've got to keep thinking about it because I might come up with a solution. Or the time I don't go back and check the door is the time when the home invasion is going to occur. And so I'm driving to work and I'm half an hour on my drive and I've just got to go back and check the front door. So these things are behavioural and these things are cognitive, and we are a behavioural and cognitive machine. So the thing that I'm encouraging everybody to have is a self-aware mind. If you can be able to say, does that really make sense? That thought that's coming into my mind, or am I better to just let it go through to the keeper and get on with my day? Whereas so if a thought comes into your mind, there's really two options. One is that I can worry about it, go through it in my mind. What's wrong with you? Why does this always happen? Um, the feared self that I could actually be a Dr. Jekyll's to Hyde. I don't know if you understand that metaphor these days, but I could be an evil person, but I just pretend to be a good person. Now, what we're saying is that if you focus on the intrusive, unwanted thought, it's not going to go away. It's going to form its own circuitry in the brain, and it's a very powerful circuitry because, generally speaking, it takes years and years for people. Once upon a time, they worked it out. It took about 10 or 15 years to diagnose OCD. And I've seen many people that have come for treatment who have had OCD for 30, 40, 50 years, and they've just put up with it. But so the point I'm making is exposure, that is, face it, accept it, sit with it, and let time pass. And just get on with your own stuff, because the intrusive, unwanted thoughts, I think it is pretty remarkable to know that everybody has weird thoughts. Now, a lot of people say, "Oh, I don't have weird thoughts," and I say, "Well, I don't believe you." What about your dreams? You've got some control over your dreams? Oh no, well that's different. That's your dreams. And I say, well, it's the same mind, the mind that has an unconscious component and a conscious component. We forgive ourselves if we have a horrible dream and we wake up and think, oh, whew, that was just a dream. We forget about it. But OCD fools people into thinking that bad thought, bad mind, bad person, and I can't possibly tell anybody about it or seek help. And that's one of the things that is very sad for uh, therapists who treat OCD, is that there are people who have not got the capacity to change, and they won't face their fears. And that's why I'm saying that the most effective way is one-to-one coached or small team. That was one of the things I think the Bergen program does very well. It has a lot of group discussions and group support, and that seems to provide a good learning experience for the changed behaviours.
Thank you, Dr. Chris, for the answer to the question. We also have like the last two questions, if it's possible. The question is, what systemic barriers do you encounter in delivering OCD treatment, and how do you advocate for change?
Well, you see, now I become very political, you see, and we say that there are something like between 30 and 40,000 registered psychologists in Australia, and this is a workforce that is university trained, and they have advanced knowledge of adaptive change and problem solving and ways of helping people, and but the government, in their wisdom or lack of wisdom, they allow people 10 sessions a year for treatment. Now they say, no, it's not meant to be serious treatment. It's only meant to be for mild and moderate conditions. But that's not what happens in the workforce. In the coalface, people come with very severe and very disruptive problems, and so the systemic issue is that there's always conflicts of interest. Everybody is pushing their own barrow, and mental health is talked about as being important, and our footballers are very worried about their mental health, and it's talked about as a kind of a meme these days. But the people that need help are people who are distressed by their symptoms to the point where they can't function. Now, it's still a long answer, I know, but back in the census of about, I think might have been about the early part of the century, of this century, maybe, I can't remember what, we're due for a census next year, so that's 26, so you could track it back, might have been 202 or something like that. They took out a group of 10,000 subjects, and they gave them a mental health questionnaire, and and the outcome of that data released by the Census Department was that anxiety disorders were the number one mental health condition, ahead of depression, because depression was always considered to be the common cold of the mental health field. But in fact, it was in this particular group, a big sample of 10,000 people. And then when they were breaking down the figures for the severity of the anxiety disorders, the anxiety disorder that stood out from all the others was OCD. And so it was shown to be the most disruptive and damaging, and the criteria it was based on was loss of days at work and losses of jobs in relation to being let go because of their OCD. Now, this was because people with OCD, they couldn't get to work on time because they would take hours to leave, and they could not participate in team meetings after a certain time. So the people, I'm talking about skilled engineers and architects and things like that, they'd lose their job, not because of their capacity, but because of their mental illness. Now, so the systemic issue there is it's not recognised as being worthy of support by the by the government. And I think the outlay on mental illness or mental health is not in any way commensurate with the amount of people who are diagnosed with mental health conditions. I think it's way out of proportion. And so that's a systemic point. And when I say that in my opening comments, when I said not everybody is equipped to deal with OCD, psychology is a very broad field, and you can't expect people to have expertise across the board. So the advice that I would give to people is to have particular interests. And I mean, it's not only psychology, but the medical profession are the same. They specialise and work in that way. But we need inpatient care. We have one inpatient program that I was associated with, which is located in the Melbourne Clinic, and that's been running for about 20 years. And in America, they have many inpatient programs, and many of which I have visited. And it's a very sad thing to go into a very big hospital in the States and to see a group of children aged 9, 10, 11 or so, about a dozen of them, sitting around in a group and getting treatment for OCD. And their parents they would be there for a whole term. And the parents would come, and sometimes they do 2 terms. So those sorts of awareness that treatment requires input like that, that's a systemic barrier. It's also a cost barrier. But when we are looking at what I'm talking about, there's no reason why there can't be short form treatments available and very skilled people able to access them without having to be trained and supervised and attend conferences and all this sort of stuff. You've already got a qualification as a registered psychologist. You need the workbook, and the workbook that we've got we give to our patients, and we use it ourselves, and it forms a kind of pattern for what to do. And when you slip back, you can go back over it and refer to ideas that you've got about before. Because one of the things that happens is in life is that we do have relapse, but we also are able to cue ourselves back into how did I handle that one other time? Because we've got that mind that can travel back, travel forward, and have available to it. It's a really an amazing thing simultaneously. Like, it's not like other mammals. They've got to do things by trial and error. But we can hold up in front of us multiple responses, and we know that ourselves. Because if we talk to ourselves, as we all do, how could I handle that better? And what options have I got? And work through it. But in these cases where the person's overwhelmed, they need the support of that coach. And so if you've got no sportsman will get anywhere unless they've got a coach. Prime example of that is our own, I don't know how far this webinar's going, but our own wonderful player, Kyrgios. He never ever thought he needed a coach. And I don't think he fulfilled his potential, unfortunately. I think we all need a coach. So I hope that's answered the question, or not just a whole lot of meandering. But government is not supporting mental health, and we have got a workforce already ready to go. We've got counsellors, we've got social workers, we've got all sorts of mental health experts, but we don't fund them. And that's why we've got such a sorry society at the moment, where the amount of violence that we're experiencing is unbelievable.
All right. Thank you, Dr. Christopher, for answering all the questions from our audience and with your excellent presentation as well. Unfortunately, our time is already up. We've come to the end. And now I'd like to take a moment to thank each and every one of you for joining us on our today's highly informative webinar on the Melbourne Intensive Therapy Program, a short form treatment for OCD. And once again, thank you so much for joining us, and we look forward to seeing you next time at our next webinar. And for more information, please visit our website www.mhfa.org.au. So it's the end. Thank you so much, and I wish you have a great day.